Greetings. I am K. Radhakrishna Menon, Vice President, Content Development Training and Conferences, National Association of Palliative Care for Ayush and Integrative Medicine. I would like to present before you today the national scenario of palliative care prepared by Dr. Mona Rai, National Assistant Vice President, National Association of Palliative Care. Indian scriptures are rich in the way medicine and surgery were practiced here centuries ago. The science was known to us way before it was known to the West. Samhita Sushruta is one of such compilations of great works of Sushruta, the famous surgeon. Over the years and with many invasions, the rich culture got diluted and India started to copy the West. The West was, on the other hand, closely learning and following the Indian scriptures. So, what had been in India for centuries came back to via Europe in an attractive package of the West. Yoga became popular when West realized the benefits and started to practice. It was then that the Indian population in general became aware of the benefits it held. India has always been a spiritually and culturally rich country. People have lived with an awareness of life and death. Vedas mention of the four ashramas of life, brahmacharya, grihastha, vanaprastha and sannyasa. This concept was practiced in olden times. Our great grandparents chose to be in places of spiritual significance like Rishikesh, Mathura, Varanasi, Dwaraka, Chitrakoot, etc. during the last years of their lives. That was a way of closure for them and a path towards salvation. I have mentioned in my slide about the Mumuksha Bhavan in Varanasi. It is based on the concept of hospice care, where the people come in to spend their last days of life, praying and chanting the name of God, and finally leave the mortal body. There is an awareness and acceptance. Santara in Jainism is another those of practices. The point I wish to drive home is the developed world learned Hinduism and imbibed it, and we were made to forget. The point I wish to drive home is the developed world learned Hinduism and imbibed it, and we were made to forget the nuances we possessed by medicalization of the process of dying, whereby losing the quality of life and the dignity in dying. The whole palliative care initiative began during the 1950s. 3 important surveys of end of life care were undertaken. In 1952, a report based on the observations of district nurses throughout the UK of some 7,050 cases published by the Marie Curie Memorial Foundation revealed appalling conditions of suffering and deprivation among many patients dying of cancer at home. By 1960, Glyn Hughes had conducted a nationwide survey for the Gulbenkian Foundation. Hughes noted a serious gap in the National Health Service with an unanswered question of where and by whom the elderly terminally ill would be cared for. Finally, a unique detailed study of the physical and mental distress of the dying was published by John Hinton in 1963. His observations from the wards of a London teaching hospital showed that much suffering remained unrelieved, and also how most patients were well aware of their prognosis despite the lack of information normally given at that time. On the basis of the experience and evidence described above, a project to show how to address the proven gap in National Health Service provision was launched as a new charity. From 1959 onwards, detailed memoranda presenting the need and the scheme were circulated to likely advisors and supporters. A steering group and countless correspondents were drawn into a rigorous discussion of the challenges and possibilities. These beginnings pointed to work that would be conducted when the new hospice was finally built and opened for inpatient and home care and for research into the relief of distress. By the end of 1960, these issues had been addressed and a basis laid for future development. St. Christopher's Hospice opened in 1967 with a building for 54 patients, a 16-bed residential wing for the elderly, a nursery for starved children, and a planned bereavement service. Home care started nearly 2 years later. The demonstration of appropriate scientifically based patient-centered treatment, first demonstrated in St. Joseph Hospice and later in St. Christopher's Hospice, eventually led to the establishment of a recognized specialty in 1987 in Australia, New Zealand and the United Kingdom. Spearheading palliative care in India since Padma Shri Dr. M. R. Rajagopal, also known fondly as father of palliative care in India, founder director of Palliative India. Dr. Rajagopal's advocacy has contributed to amendment of Narcotic Drugs and Psychotropic Substances Act of India in 2014 and in its implementation a critical step in reducing needless suffering and allowing millions to access pain relief. He was also the prime mover in the creation of the National Program for Palliative Care by the Ministry of Health of Government of India. In 2014, Rajagopal was honored by Human Rights Watch with Alison Des Forges Award for extraordinary activism in recognition of his tireless efforts to defend the right of patients to live and die with dignity. It was with the consistent efforts of Dr. Rajagopal that created the awareness about palliative care in India. He started the movement and many joined. A lot of agencies have come together along with the government and are putting in all efforts to push through palliative care, which is the need of the hour, and especially in a country like ours where disease burden is huge. Advocacy is not something that comes naturally to most medical, nursing and allied professionals. However, without it we cannot make progress. The palliative care community in India has to get its act together to reach out to lawmakers and bureaucrats and demand adoption of minimum palliative care standards by the healthcare system as a whole. Naturally, this will mean considerable public and media advocacy and also significant governmental advocacy. A study done by Lean Foundation on Quality of Death Index found India in an abysmal low of 67th position, indicating that India is one of the worst countries to die in. 45% of countries have no access to palliative care. In fact, the global burden of serious health related suffering is expected to nearly double in the next 4 decades, according to a new study. In 2018, the Lancet Commission on Palliative Care and Pain Relief stated that no other important health intervention is as lacking or inequitably distributed as pain relief, the pillar of palliative care. This is quite in tandem with what we as doctors see in our daily practice, except we choose not to take note of it. But the data says it all. The situation of LIMC is pathetic. 75% of the population of our country belongs to the rural India. They reach tertiary centers only after they are in advanced stages of their disease. Multiple factors are responsible here: illiteracy, lack of resources screening, poor primary health and lack of money. A single day of work gone is equivalent to the family going hungry. When they reach in the advanced stages of their illness, palliative care has a huge role in relieving the suffering. It certainly won't change the trajectory of the illness, neither the fate of the person, but will certainly make the journey bearable for the patient and their families. It also encompasses bereavement support and whatever can be done to mitigate the suffering. The palliative care movement is one example of how health services can go well beyond the biomedical model of health and be seen as an affirmative act of living with dignity, even whilst accepting that death is an inevitable part of life. The concept of palliative care is relatively new to India, having been introduced only in the mid 1980s. Since then, hospice and palliative care services have developed through the efforts of committed individuals, including Indian health professionals, as well as volunteers in collaboration with international organizations and individuals from other countries. In 1975, the Government of India initiated a national cancer control program. By 1984, this plan was modified to make pain relief one of the basic services to be delivered at the primary health care level. Unfortunately, this policy was not translated into extensive service provision. The hospice and palliative care movement in India started tentatively in the mid 1980s and has slowly increased over the last 2 decades. In India, the earliest facilities to deliver palliative care within cancer centers were established in some places like Ahmedabad, Bangalore, Mumbai, Trivandrum and Delhi in the late 1980s, early 1990s. Palliative care was initiated in Gujarat in 1980s with the opening of a pain clinic and palliative care service under the Department of Anesthesiology at Gujarat Cancer and Research Institute, a regional cancer center in Western India. One of the important steps in the history of palliative care development in India was also begun from here, forming of Indian Association of Palliative Care. In 1986, Professor D'Souza opened the first hospice, Shanti Avedan Ashram in Mumbai, Maharashtra, central India. At a similar time, pain clinics were established at the Regional Cancer Center Trivandrum, Kerala, with the assistance of a WHO subsidy, and at Kidwai Memorial Institute of Oncology, Bangalore, Karnataka. From the 1990s onwards, there was a significant increase in the momentum of development of hospice and palliative care provision. This was demonstrated through both an expansion in the number of services as well as other key events and initiatives. CAN Support was founded in 1997 in Delhi, which provided first free palliative care home care support service in North India. In Pune, Maharashtra, Central India, the Cipla Cancer Palliative Care Center was established. The Indian Association of Palliative Care was registered as Public Trust and Society in March 1994 in Ahmedabad. IAPC held its first international conference at Varanasi in January 1994 with the assistance of WHO and Government of India and adopted a constitution. The following year, the IAPC set up a palliative care drugs committee, an educational task force, and held its second international conference in Ahmedabad, where 180 delegates attended. There has been a lot of progress in palliative care in India, but the fact remains that despite the passing of almost a quarter of a century of palliative care activity in the country, even today palliative care reaches only about 1% of the people in India. If we take per capita consumption of opioids belonging to the step 3 of the WHO ladder as a criterion, this has been on a plateau for many years now. India is still at that phase when it seems poised to leap forward, though the dynamism is yet to be manifest in the following 3 areas. The NDPS Amendment Act is simplified now, but needs to be implemented by state governments. Non-government palliative care organizations who already are struggling with positive resources will have to take the onerous task of finding funds and personnel for catalyzing government action state by state through 29 states and 6 union territories. Despite a submission before the Supreme Court of India expressing willingness to incorporate palliative care in undergraduate curricula, and despite the palliative care community preparing the curricula and giving a framework for implementation, the Medical Council of India and the Indian Nursing Council are yet to act on the matter. Though the national program in palliative care was created in 2012, due to lack of budget allocation, only a tiny part of the program has been implemented. Even for the part that is funded, considerable catalytic work is needed for the state governments to ensure that proper plans are made and implemented. In short, some major barriers to access to palliative care in India have been overcome, but implementation of created policies and laws still require massive efforts by both the government system and non-government organizations. The non-government organizations do have the commitment, but would need international support to effectively facilitate government activity. The recent declaration by the World Health Assembly 16 asking all member states to integrate palliative care with routine health care comes as a major tool in advocacy and hopefully will boost the current efforts. So, thank you for viewing my presentation.